Okay, doctor. I guess we're ready to kick it off. We're past 6.
Okay, that's good. Tim and I were debating the issue whether this should be kind of back and forth discussion or should I have a planned talk about it. And I eventually decided I think it's much better to have a free dialogue than a canned speech. The most important feature of treatment of facial pain is the diagnosis. What is the diagnosis? Because all of your treatment really depends upon the accurate diagnosis. And unfortunately, from a scientific standpoint, this is basically a clinical diagnosis. We still do not have any test that you could say this is trigeminal neuralgia or this is some other kind of pain and so forth and so on. And that's why it's very critical to have that detailed discussion. And there are times that you have to, it's more like I tell patients, it's like an FBI interview. You get asked questions, same question many times from different angles, till it becomes clear what kind of trend the pain has. Actually, what I think most valuable is to actually go back and look at how the first episode was. Because the very first one actually tells you a good story. So I have one of the patients who drove back home after a day's work and was in the garage, got out of the car, and got terrible pain that went right into his forehead, affecting the eyebrow and the forehead. The pain was severe enough that he actually dropped down to the ground and hollered at his wife, who came and helped him. And then he was fine. But because the location of the pain was such, in the forehead, around the eye, he ended up talking to his internist, who then referred him to an ophthalmologist. And they did a few of the studies, and they sent him to a cornea specialist. And he was heading in that direction. And I had known him. So he mentioned to one of my colleagues that he got this terrible pain. And that, every time I touch my eyebrow, I get this sharp pain. He said, well, Dr. Malik, you should go and talk to him. So as I listened to him, I told him that he has trigeminal neuralgia, little unusual to affect, this first division. Mostly we see it, when you look at the trigeminal nerve, the reason we call it trigeminal because it has 3 branches. Branch 1 goes to the eye and the forehead. Number 2 goes to the cheek, the upper lip, upper jaw, and going a little bit into the temple. And the 3rd division comes down to the lower jaw, down in front of the ear, and goes up along the side of the head. So more common is the 2nd and 3rd division. The 1st division is relatively, actually quite uncommon, except in cases when you have shingles or herpes zoster and you get pain after that, that is more commonly affecting the first division. So that's one of the reasons they did not think about it, because it's uncommon. But when you go back and listen to him, here's a person who is perfectly normal, and he gets this shock-like sensation that gets him down to the ground, and then the pain goes away. It could not be any inflammation or anything happening to the eye, because that would come on slowly, that would persist, and so forth. And for the last 4 years or so, he actually has managed this pain with very small dose of Tegretol or carbamazepine. He takes only 100 milligrams twice a day, and that has controlled his pain. And that's one example, and there are tons of examples where you really need to get a good interview. And most of you know that we have classical symptoms of trigeminal neuralgia that these days we refer to as TN1. And that diagnosis is very easy if you actually do listen to the patient. Sharp shooting, lancinating pain comes on suddenly. You've got trigger points. For example, this patient I was mentioning from yesterday could not touch the upper lip, could not brush, and so forth. Or the other patient I mentioned, touching the eyebrow initiate the pain. So they have trigger points. And in between those spells, the pain goes away. Now, most of the patients who have been having pain for a longer period of time will say, "Oh, doc, it just goes on for half an hour, it goes on for 2 hours. I suffer for it for 3 hours, maybe a day or so." Yes, when you start having these spells, they may linger on for a day. But then you actually pin them down. You'll say, "Oh no, I get this shock that's mostly in seconds," and then it settles down. And maybe over a period of time, you have some background pain. So that's first part of it. The second is you have a mixed syndrome that is getting different names. We used to call it atypical trigeminal neuralgia. Then we started talking about TN2. That means it has some of the features, typical features of trigeminal neuralgia. But then there is some pain that lingers on all the time. Or there may be some sensory changes, tingling sensation, dull aching, and so forth. Or having had some dental procedures that you feel that might have caused the pain, although most of the times people go to the dentist because the tooth was hurting. So the first diagnosis was trigeminal, it just didn't get picked up. So we're kind of drifting to a terminology of neuropathic pain. That means there has been some damage to the nerve, whether there was inflammation, there was injury, there was compression, different things that has caused the pain. It's a little bit different than the typical trigeminal neuralgia. And then we go on to a group of patients where we actually cannot really pin them down. Some you can figure out, like TMJ problems and so forth. The others you don't. The question then comes up, if you have a diagnosis, we recommend that a person get, before it used to be the CT scans and now an MRI. And there are some sequences on MRI that give you thinner pictures, Fiesta images, we call them, or CIS images, and can show the nerve and the surrounding structures better. But in my mind, The basic reason to do those studies is to figure out that there are no other complicating factors, because patients can have a small tumor next to the nerve that causes irritation and causes pain, oftentimes also associated with some numbness. You could have a blood vessel malformation, as we were just hearing a little while ago, that might be an AVM, might be the reason. You want to look for some cysts. There's one more typical one, we call it epidermoid cyst, and those are associated with pain. Other inflammations, and primarily in the younger patients, we worry about multiple sclerosis. So that is the reason to look for the MRI. If you see some pathology very much close to the nerve, that's helpful. If not, it doesn't really preclude the diagnosis of trigeminal neuralgia. But one should somewhere along the way get a good MRI. And the treatment, obviously, we all know that it responds pretty well to these anti-seizure medicines or anti-epileptic medications. The more common being carbamazepine or Tegretol, or oxycarbamazepine, that's the Trileptal, and some of the other medications that are also used for seizures. And then we have some other ones that are being used as second-line treatment or added treatment and so forth. Treating the patient with medication is very appropriate. As you start having pain, having a diagnosis, having a diagnostic study, and then treating it with medication. And we subscribe to the notion that the primary treatment is medical. But the medications, you have to take them in order to control the pain. It's no different than having diabetes or having high blood pressure, that as long as you take medication, you have control of that condition. Or if you have seizures or epilepsy, you have to continuously take the medication. Same is true with this condition. Medications may be helpful, but one really has to take the medication. It may vary depending upon this number of spells that one is having. What I have noticed is that there is definitely more resurgence of symptoms in the spring and fall. We see more patients during that time. So the weather changes have influence on it. And so patients who are on medication, they may be able to reduce the medicine if there has been no pain for a couple of months, but you reduce it slightly, pain comes back, you add it on. So most of the times patients are able to manage the pain. I think where some of us might differ is to what extent one should stay on the medication and how much medication one should take, because they do have side effects. They are all anti-seizure medicines. They slow down the thinking process. They may cause dizziness, unsteadiness. You may have effect on blood counts, certainly on sodium. It may go down. So if the side effects happen, then one has to think of other treatments. But there are times that we actually push the medicines too much, which I think is probably not needed, because it may control the pain, but if you are not able to function well, then it's of no use. So there are some patients who go on to 3 medicines, 4 medicines, and it just makes them really sick. So at that stage, if this reasonable amount of medication that's not causing any side effects, I think is the way to go. That's how to treat it. The most effective ones, obviously, are the anti-seizure medicines. There is a big debate as to the role of opioids. They generally are not effective against typical trigeminal neuralgia, as we know, but they may be helpful against neuropathic pain. Some of these other medications that are used for neuropathic pain elsewhere might also be helpful. There is a significant interest in the use of marijuana. I have no personal experience in it, prescribing it, so I can't quite tell you. But some people feel that it is helpful. The beyond medicines, then we have surgical procedures. Now, before we started the meeting, we were talking about microvascular decompression. This is based on the observation that in majority of patients, it is a blood vessel around the nerve where the nerve enters the brain. We call it root entry zone, that the blood vessel causes compression in that location. And over a period of time, the insulation on the nerve fibers is affected, and it results in kind of short circuiting and causing these episodes of pain. There are multiple observations that actually support that notion. In addition to, at surgery, finding those blood vessels. The first part of it is that as we grow up in age, the blood vessels tend to become stiffer. So if you had a blood vessel that had a kink that was next to the nerve, they are normally supposed to be there. They supply the blood to the brain, or they drain the blood away from the brain. So over a period of time, that loop or that bend in the blood vessel, or simply by its location, it would become stiffer and cause pressure on the nerve. And that is why the onset of this pain is most commonly in late 40s, in 50s, and 60s, rather than in teens and 20s and 30s, because the blood vessels are softer. If it does happen at a younger age, it's more commonly the veins rather than the arteries. So the arteries carry the blood from the heart, and they are under pressure, like if you feel your pulse at the wrist, but if you can't feel pressure in the veins on the back of your hand. So this procedure came about whereby you would go behind the ear, about $half size opening in the bone, and with the microscope, and one of our late associates used to use endoscope, you look in there, you free up the blood vessel from the nerve, and then you put a little Teflon padding between the nerve and the blood vessel. So the procedure is aimed at not causing damage to the nerve. That's why it's called decompression. It's called vascular decompression because you are moving the blood vessel. It's called microvascular decompression because you're using a microscope through a smaller incision and freeing up the nerve. This has the most success, at least in my own experience. Its success rate is somewhere around 90%. Because there is no medicine, there is no procedure that has 100% success rate. But 90% is very high success rate. And it has the most longevity. Now, all of the procedures that we do have the risk of pain coming back. We call recurrences. And I'll go over some of the other ones as to the numbers. Obviously, the statistics and the numbers mean nothing for one patient. An individual is an individual. You cannot divide one person into 90% and 10% and so forth. So for one individual, it's a matter of all or none. But when we look at this 85–90% success rate, you are looking at getting rid of the medication and being free of pain. Following the patients for 15–20 years, about 75% of the patients have remained free of pain.
That's amazing.
But so the others do get some recurrences, some earlier on and some late, sometimes minor recurrence where you could take a small amount of medication, and others may need some other procedure to help with the pain. So if we were starting de novo at the very beginning of it, and the patient's health is good, you're not dealing with a lot of medical problems where the surgical risk is going to be really high, I would think, and it may be my biased opinion, but I think that the first line of treatment out of surgical procedures should be microvascular decompression. If it fails, you could always do other procedures. All of the other procedures are termed under ablative procedures. That means you're causing a certain amount of damage to the nerve in order to tame it down. So if you're going to go the route of surgical treatment, then you want to preserve the nerve because you could always do the other procedures. But if the nerve is damaged and you get some numbness or you get other symptoms, then you could still do microvascular decompression, but it may not be as effective. Risks. So the risks are divided into two groups. One is the general risk of surgery. Anybody who is having an operation has a certain amount of risk. It's a procedure that takes, around on the average 4 hours, maybe less, maybe more. So you have anesthesia. You always, whenever you get a cut, you worry about infection. Although these days the risks of those things is very minimal. But as I said before, minimal means nothing for one individual.
Mm-hmm.
Heart problems and so forth. The second portion of it is any surgery is the risk to the tissues where you are doing the surgery. If you are operating on the heart, could there be damage to the heart? If you're working on the stomach or the liver, same way whenever we work around the brain, this is not the procedure inside the brain. It's actually a procedure between the skull and the brain. But still, you're working around the brain, so you could get bleeding, you could get that portion of the brain has to do more with balance. Could it affect the balance? And we were talking earlier on, there is the nerves close to this nerve. So on one side, there's a very tiny nerve that's called fourth nerve. Now this part of this group of 12 nerves that come from the base of the brain and provide all these senses, like smell, like eyesight, like eye movements, sensation of the face, movements of the face, swallowing, tongue movements. So number 4 supplies one muscle of the eyes. And if that gets affected, it causes double vision. Now, if it's not totally damaged, it tends to recover. But it's only one muscle. So let's say even if it gets affected permanently, it's possible to correct that with prisms and sometimes even shortening one of the muscles. So it's not a terribly devastating problem. The other nerves are the nerve to the hearing and facial movements. That nerve has much lesser chance of being affected. So those are kind of the risks. Obviously, it is an open procedure. It does hurt. You know, the incision has to heal for a few weeks or so. But it's gratifying. As I said, the other procedures are ablative procedures. So we use radiation. It's called radiosurgery or gamma knife. Linda had cyber knife. The whole idea is exposing the nerve to the radiation. Single dose. It's an outpatient procedure. The effect, some patients have reported having benefited from it within a very short period of time. Maybe the next day the pain is better. But generally, it takes about 2 to 3 months for it to be effective because radiation does not work right away. The recurrences from it are more common, probably more common within first couple of years. And success rate is about 75 to 80%. The difference is that 75% success rate is with or without medication. In some patients who were taking medicines and the pain was not controlled, now the pain may be controlled but still have to take medication. That's how these statistics have been gathered. So it's a little harder to know exactly, but anyhow, about 75%, but recurrences are not uncommon. And it's based on causing a certain amount of damage to the nerve. The other one is using radiofrequency heat, where you go with a needle through the cheek, through the base of the skull under X-ray control and short anesthetic, back into the nerve, and you heat up the nerve with radiofrequency heat. And that causes numbness in the face, in the area that the pain is. It's also very successful in essentially about 90% of the patients. However, the recurrences with that one are much more. You know, I have had patients that have gone 8 or 10 years, but that's relatively uncommon. You know, you see recurrences more within few years, and some even much earlier, depending upon how much numbness did you create. We can use chemicals like it's called glycerol, which is toxic to the nerve, done the same way like radio frequency. You go with a needle through the cheek and you inject glycerol, and that causes a certain amount of numbness and controls the pain. Results are similar. We have going with a catheter through that needle with a balloon at the end and blowing up the balloon temporarily, causing damage to the nerve, balloon compression test. So these are kind of, these days, the standard for regular TN. Then we have patients who end up having what we call anesthesia dolorosa. If you create numbness, about 8 to 10% of the patients don't like the numbness. It's very bothersome to them. And that we refer to as anesthesia dolorosa. They are numb, but still hurting, painful numbness. And that is very difficult to control. And that's where motor cortex stimulation has been tried, where you actually go and do the operation on the head in the area that controls the motor function on the opposite side, and put an array of electrodes so that you could stimulate those electrodes through a battery-operated like pacemaker. And some people have actually reported very good results. Journal success rate about 40 to 50%. And even in those patients, 100% relief of pain is very, very uncommon. But that is for a complex problem that we don't have another solution for. Then for similar neuropathic type pain, the stimulators, nerve stimulators are being used in selected cases where you actually put the stimulator, wire stimulator underneath the skin, and you can change the frequency for it. And these stimulators were being used more in the spinal cord for spine problems and back pain type patients, but they are being extended to this area. There has been some success in putting the stimulator in the upper part of the neck, because portion of this nerve, these nerve cells come down into the spinal cord, upper part of the neck area. And, but there again, the success rate has been not very high. And we're still looking for other solutions. A lot of research goes on all the time. So I'm open to questions, explanations.
This is Melody. Can you hear me?
Sure.
Yes?
Yep, we can hear you, Melody. Yep, go ahead.
Okay. I just had a question for the atypical, or the trigeminal neuralgia 2, which is what I have, and I have read a lot about it, and even talked to some doctors about it and stuff, but it seems that surgery is not an option for this type. I mean, that's what I'm gathering, that surgery is not an option, and it's just pretty much whatever medications you can find that to get your pain under control. Is that correct?
Well, so what did they call this?
We believe it's TN2, Doctor.
Pardon?
TN2.
Yes, TN2.
TN2. So TN2 actually is responsive to surgery, but the level of success is not as good as TN1. So you have to really define it, because TN2 has two kinds of pain. You have one group where you have actually pain like TN1, and in between you have constant pain. You may have some burning pain, you may have aching pain, but then on top of that, you get these spells where you have sharp shooting pain that lasts for a very short period of time. And it may have a trigger or it may not have a trigger. So if there is a component of this sharp shooting pain, and that's why you will call it TN2, because if there is no component of that, then you have to just simply call it a neuropathic pain, which we in the past used to call it atypical facial pain. For that, there is really no surgical treatment. But if it's a mixed type of pain, surgery is helpful, not as good as TN1. So one really has to think that over, dissect the symptoms, and then decide about it. Now, where it's not helpful, if you have pain related to shingles that we call post-herpetic neuralgia, there the surgery has really no role, and that's where the motor cortex stimulation or other stimulators might be helpful.
Well, doctor, I have a question. If it's just neuropathic pain, just that, and maybe damage from dental work or whatever, why would that happen?
Why does that happen?
I know that. Yeah.
Yeah. You know, obviously we don't know all the nature and causes of this pain. It is the effect of the nerve. This nerve is a sensory nerve. It basically carries the sensation from the face back to the brain. The touch sensation, pain sensation, and if there has been a damage to the nerve, and that can happen also in the arm or in the leg, let's say was there a car accident or other accident, and you cut the nerve, the area may be numb or it may become actually painful. You know, sometimes you have what we call neuromas. The nerve tries to repair itself, but actually forms a knot in there rather than those fibers going in the same direction like the previous ones were. So some of this is not understood. I think the reason we have ended up having those sub-classifications is primarily to look at what kind of treatment you can provide. Because if you're going to subject somebody to a certain treatment, there has to be a decent chance of success. Right. And that's why, as I started saying, the diagnosis is very, very critical. And there are times that you have to talk to the patient 2 or 3 times before coming to a definitive conclusion. Now, now one other way we also judge it is that medications like Tegretol are very effective. They may have side effects. They may not totally eliminate the pain, but they are actually very effective. So if you have pain which is a little different, but let's say it responds to medications like Tegretol, that also lends support to this being a component of this being trigeminal neuralgia, rather than totally neuropathic pain. So those things, you take into consideration all of those issues before coming to a consensus.
How are the meds working, Dr. Pepler, Melody?
Yes.
Pardon?
How are the meds working from Dr. Pepler?
Good,
Good.
good. Thank you, Tim.
You're welcome.
Thank you very, very much. He's been great.
Good. Who's joining us on the phone number that ends in 499?
It's Tom Rorbaugh, Lake Leland.
No, there's another one, Tom.
Yeah, we have a different, 248 ending in 499.
No,
It's Denise.
Who is
Who?
it?
Denise.
Denise. Okay, welcome, Denise.
Okay,
Sorry.
Denise.
Thank you.
Which Denise?
Denise Boyer.
Boyer. Oh, gotcha. It's been a while. Goodrich, right? You in Goodrich? Okay.
I
Go
don't
ahead.
think she heard it.
Yeah. Marlene, did you get your question answered about risks?
One of the questions I had, doctor, was if you had the MVD, did you say what the risk would be of numbness in the jaw after the surgery?
Very low risk. You could get numbness because you're working around that nerve, and the sensory nerves are a lot more sensitive than the motor nerves are. The motor nerves have a much better tolerance, and so yes, you can get some numbness.
Is it something that
But
goes away?
that's not intentional.
Right, right. But is it something that goes away or stays with you?
It depends the degree of numbness you had, but most of the times, if the numbness happens, it's kind of patchy or minor numbness. That tends to, even the other numbness tends to get better. When we do these procedures, radiofrequency ablation or glycerol or radiosurgery, and they are associated with numbness, the numbness tends to improve.
Okay. Can you define TN1? You define TN2. What's the definition of TN1?
What TN1 is this horrible electrical type pain that comes on suddenly without the warning, and it kind of freezes you, and you can't control it. It lasts a matter of seconds, although to the patient it might seem like minutes, and then the pain goes away. In between, you actually have no pain. And now those spells might come one after the other. So if you are having a bad season or bad day, you may get multiple of those spells. And it sounds like, it was there all day long, but actually when you think about it, those in between you don't have pain. And most of the times there are what we call trigger points, where you have a sensitive area on the face. It may be the side of the nose, it may be upper lip, lower lip, which over a period of time you figure out that you're never going to touch that area, because if you touch it, it's going to bring on the pain. A lot of people have trouble brushing the teeth, talking, even brushing the hair. When different people have different pain. Now there is another neuralgia that we call glossopharyngeal neuralgia, which this is that nerve number 5, trigeminal nerve, cranial nerve number 5. Number 9 has to do with swallowing. And some patients get pain related to that. That pain is mostly in the throat and inside the ear, and it's generally triggered by swallowing. similar pain, and that's also related to the blood vessel compression, and it responds very well to the microvascular decompression.
Are you in the hospital for a long period of time after that surgery?
Most of the times it's a matter of about 3 to 4 days.
Okay.
You are at least in the ICU overnight. So I operated on 2 people yesterday, one after the other. And both of them this morning were ready to go to the regular floor. They were not experiencing any medical issues that needed for them to stay in the ICU, and probably would go home by Friday.
Okay.
But everybody is different.
Right.
But generally it's about 3 to 4 days.
Mm-hmm. Thank you.
I know we talked yesterday, Marlene, that some of the neuros are sending them home in 1 to 2 days. So as Dr. Malik said, it just depends on the patient as well as the neurosurgeon's view. I'm not disagreeing with Dr. Malik. It's just that different neuros have different views on that.
We have a different makeup.
Yep. That's right.
Okay. Some cherish getting people home the next day and feel proud of it. And some of us want to be sure that they don't go home and having other troubles. We want to make sure that they are in good shape to go home. So
it hasn't shortened with COVID then?
Not really. During the days of COVID, we were actually not operating, doing elective surgeries, and now the numbers have really, really gone down. All of the patients who are coming in right now for any invasive procedures or surgery are actually tested 24 to 48 hours before coming into the hospital.
That's really made a difference.
And so, no, we are not altering their care because of COVID.
What's the percentage of spinal fluid leakage, doctor?
Spinal fluid leakage?
Yes.
I would say somewhere between 3 and 5% or less.
Okay. I think that was one of your questions, Marlene, when we talked.
Yeah, right.
You should have notes.
Yeah.
Any other ones?
The area that we go in is close to what we call mastoid. That has air spaces, call it air cells. And when they open up, sometimes the fluid can get in there, and in the base of the skull, it tends to travel and may drain out from the nose. And in cases that has happened, you basically might have to drain the fluid through the back for a few days for it to seal off. But that's uncommon. I actually, a lot of people either cut out a piece of bone and try to fix it back in there. And some people use little screens and so forth to take away the dents and defects in the skull. I have my own special way of repairing the skull, so that seems to work very well. And most patients get some numbness in the back of the ear because of the incision, and that tends to get better too.
Marlene, how long have you had facial pain?
7 months. Well, it was first diagnosed that I had, I needed a mouth guard for my dentist, and I went to my dentist, and he did the measurement, the impression, and COVID hit.
Oh boy.
And so I couldn't get it, so I went for the whole month of March, and I called him back and I said, I'm in such pain, you got to do something. And so he sent me to an oral surgeon. and the oral surgeon is the one who sent me for the MRI.
Okay.
And then he started me on the Tegretol. And now I'm taking the Tegretol 800 mgs a day. And in the beginning, it took all the pain away. And now the pain is still down in this area, the left side of my jaw.
Have they increased it at all?
Yeah, I started at 100, then 200.
From the 800, have you gone up at all from the 800?
Not so far, no. And I think I was told 1200 is the max I could go to.
Right. Yeah.
So
Age
it,
is 10%.
it has taken that pain away from here, and I can speak better. But it's just brushing my teeth and eating that causes my pain.
Have you tried that viscous lidocaine 2% you can get from your dentist? It's like a topical, but you can do like a swish and just wipe your mouth out. So you can brush and eat. It really helps.
What's it called?
It's 2% viscous lidocaine, and it's a topical gel like they use prior to an injection.
Right, okay.
Like local anesthetic.
Yeah, it works great for that. It allows you to brush your teeth or eat just to get through and it changes like right now I'm having a lot of burning, and if I had it, I could zigzag it and it would change the pain sensation. So it would.
Okay.
It out.
Right.
Yeah,
when I went to get my teeth cleaned, he numbed it.
Okay, smart.
And then he was able to clean my teeth.
Oh, good. That's a great idea.
Right.
You know,
Okay.
some people cannot tolerate the medication earlier on, and some do. As we were talking before, there is some of our colleagues feel actually that maybe we should not let the person go on multiple medications and a long-term suffering with it, and consider doing the procedures earlier on. But as I said, I think if the medication is controlling it and there are no side effects, then it's better to stay with the medication. But once you start having side effects, because it does influence your thinking, you know, I use the analogy of these medications. They are used for seizures or epileptic fits. And the seizure happens, normally we have EKG, you check the heart, it has electrical rhythm. Same is with the brain. If we put electrodes on the head and monitor it, the brain has electrical activity that we call it EEG, electroencephalography. The way the seizure happens is because some cells in the brain in certain location, because of previous trauma or infection or the way they were developed, they start firing much rapidly compared to the normal brain. And that results in a seizure. You know, it could be minor seizure, it could be a major seizure where you go, you know, unconscious and thrash around and so forth. These medications cut down that electrical activity to tame it down. No different than if you have a crowd and few people become really rowdy and you want to tame them down so some of the other innocent bystanders get hurt. Same way with these anti-epileptic stuff, it affects those irritable cells, but the other cells are also influenced by it. So it tends to tame them down too. And that's what happens with, some people complain about effects on the memory, some on general thinking, some just activities being slow. You just don't function that well, and if there are too much medication, it might cause dizziness and so forth and so on.
Is that over the counter, Lynn?
No,
No.
you get it from your dentist.
Oh, you have to get a script for it.
Yep, from your dentist. Not even your regular doctor can prescribe it.
Oh, okay. Thank you. Okay.
Linda, I think you had a question for Doctor before we started the meeting.
Yes.
At the cyber.
I've had 2 microvascular surgeries in 2009 and then last year. I've had 2 rhizotomies and they did CyberKnife. After the CyberKnife, I have not done well. Now I have been diagnosed with fourth cranial palsy. I also have a potential AV malformation that may be giving me these symptoms. My question is the CyberKnife, can that cause damage to this fourth cranial nerve?
Yes.
It can.
CyberKnife can cause it. Gamma knife can cause it.
Okay.
Okay. Because this nerve is just next to the trigeminal nerve.
Yes.
And particularly if you have had 2 prior microvascular decompressions, then that causes some degree of scar tissue.
Okay.
It's one of the reasons that we resist the idea of re-exploration. Because if you do the second time around, working through that scar tissue, you have a much higher chance of causing numbness of the face.
I do have that completely. And numb on the inside of my mouth. I have
so that is the reason we generally tend, it would be a rare occasion that we would redo the microvascular decompression. Especially, I would not do it if I had done it before and I know that I had excellent view of the nerve and looked for any of the blood vessels. Now, occasionally, and that's also really rarely, I have explored some patients where I did not do the surgery and they were insistent on it, but still scar tissue is there. So once you develop the scar tissue, then it becomes harder to actually, then the effect of these radiation and other treatments is not going to be as precise. And the fourth nerve is just next to that nerve. It's a very tiny nerve.
Mm-hmm.
Okay, as I said before, obviously if it affects the person, it's difficult. That's not the end of the world. A neuro-ophthalmologist can give you prisms to take care of the fourth nerve, or they could do a little tweaking procedure for that one muscle, and that helps take care of that double vision. So I would not really, personally, I would not worry too much about the fourth nerve. But the concern I have about the AVM is the AVMs people are born with, unless they are talking about what we call AV fistulas, what they call arteriovenous fistulas, that could be from trauma or something. So the AVM should have been seen before when you went through all those procedures. But angiogram is the only thing that actually would clarify it. So you are on the right track.
Yes, I'm going to have that done. Uh-huh.
Lynn,
Yes.
I have to leave the meeting.
Okay, thank you for joining us, Nadine.
So it was good to see everybody, and take care, everybody.
Thanks for joining us, Nadine. Great
Thank
to see
you. Thank you.
Thank you. Bye-bye.
Bye-bye.
Well, I'm glad you're going to get that done, Linda. Let us know how you do. We'll be thinking of you.
Yeah, this has been a nightmare, just a nightmare.
Where are you having that done, Linda?
At Borges in Michigan.
In Borges?
In
Where?
Kalamazoo.
In Kalamazoo.
Kalamazoo.
In Kalamazoo.
Yes, and then depending on what they find, then I'll determine where I want to go, for further treatment. Mhm.
Yeah, Dr. Malik is in, as I mentioned, West Bloomfield.
Okay.
You're
Okay.
confident that the Kalamazoo Hospital knows what they're doing?
Not
They have a
totally.
good program.
Do they have a good program?
Certainly, they have a good neurosurgery department. Now, I don't know individual people dealing with trigeminal, but they have a good neurosurgery department.
Well, they do, but they don't do microvasculars. They do at Bronson, but they don't do them at Borges.
Oh, I see.
Yeah. Because I went there and one of their surgeons said, I don't do it. I've never done it, but I'll order the equipment. And I thought, no, thank you.
Yeah.
Do you have a way to get to Dr. Malik, Linda?
I
If
have
you
friends.
decided-
I have friends that are willing to take me wherever I need to go. And I will be in touch with this group for advice too, and links to other neurosurgeons and Dr. Malik. I need to know, first of all, is this double vision cost from an AV malformation? And why the AV malformation now? I never had it before.
That's why the angiogram would help you, whether it is there, and if it is there, what kind of malformation it is. Okay.
But it also could just be caused from the cyberknife, correct?
Yeah, I think it has a much more likelihood of being caused by cyberknife.
When was the last cyberknife you had, Linda?
June of not this year, but last year. Yeah.
If I can,
And your fourth nerve palsy became obvious in 3-4 months?
No, that just came up this month.
This month.
Yeah, this month. Well, a month ago, I should say. Yeah.
Okay.
And it's been, I just don't get any reprieve. I live by myself and I have total double vision.
Well, some simple way to do it, they must have told you, you patch one eye and you would not have double vision.
Yes, and I know that. It's such a weird thing. It's like being in a fun house, but it's not fun anymore.
No.
The distortion.
if I can pick you up, Linda, if I can help get you to Dr. Malik, let me know.
Okay. I'm just sad. I'm just sad. I've been through so much.
We're
We've been talking about that for so long now, between Linda and I with you, that I think we need to try to get you to, at least for a second opinion, to Dr. Malik if he's willing to see you.
I'm just I'm just downhearted and I'm losing my spunk,
Yeah, worry about it.
For so long.
Yeah.
My mental health care is taking a hit with all this. Yeah.
Well, try to keep that in mind.
We can certainly talk about it.
Yeah.
You've gone through the regular channels of these procedures, and once you start having ongoing symptoms despite all these procedures, then it becomes more difficult, particularly developing anesthesia dolorosa and so forth. That is.
Do I have anesthesia dolorosa? It's my big question.
Well, so if you are numb,
totally numb. I'm numb.
And you're still hurting, that's the definition of anesthesia dolorosa.
Yeah.
I have burning pain, continuous, and total numbness.
Yeah. So you got anesthesia dolorosa.
Oh my God.
Okay.
Which is probably the worst diagnosis ever, isn't it?
No, there are a lot of worse things in life. Okay. But that is not responsive to these usual procedures that we do for trigeminal neuralgia. That's where the motor cortex stimulation has come into picture. That's where the nerve stimulators have come into picture in trying to treat that.
So do you have success with nerve
Doctor,
stimulators?
Well, I actually don't do it. We have another colleague who does the stimulators. He actually is puts the stimulators for Parkinson's disease, and also for this kind of a thing. So we could certainly ask him to see you.
Okay.
yeah.
We found, Linda, that opiates with some people around the TN system have found them to work. It's just a matter of finding a pain specialist in our current day that will prescribe them, and then your willingness to take them. But numerous people around in the TN world, well, I say numerous, I shouldn't say that, but we've had occurrences of that I've talked with, and they found that opiates, not to say that the stimulator that Dr. Malik's talking about wouldn't work, but opiates are an alternate.
Okay.
Has she tried those?
It didn't seem.
Linda, have you tried those?
I tried tramadol before, and it didn't seem to help.
And you need something stronger. Morphine or one of those.
Yeah.
This isn't in Dr. Malik's area, but it's outside of the neurosurgical
I have
world.
a question is why I have a question, you guys, is why with neuropathic pain does opioids help? Why? When they say that it's nerve pain normally isn't helped by that.
Because I think it's because it's constant. It's versus like the sharp shooting shocks that you can't predict when they're coming or going. But ours is constant. I've had mine for 25 years. It never.
So what we do, Melody, I think I explained before, the Neurontin, gabapentin, Tegretol are for the shocks or the microvascular decompression, and the constant pain can be treated with opiates. And then
Right,
Dr. Malik talked about other alternative surgical procedures as well.
I'm on the gabapentin. They never put me on the Tegretol, but they did try me on the Oxteller.
Yeah, that's the trileptal, which is they are
And
equivalent.
Yeah, the trilipitol, right.
Yeah.
And that didn't work.
So they are the same. They're the same. Same
You
family.
don't have the shocks though, right, Melody? Yours is mainly constant pain. Correct?
My pain isn't constant, but it's enough throughout the day to you have to do something, you know. Night is worse. For some reason, nighttime, evening, it accelerates.
What about when you're sleeping?
When I'm sleeping, I don't feel pain.
Okay. Yeah, that's typical.
What did Dr. Packer put you on to handle your pain?
Yeah, he put me on the hydrocodone.
How much?
5. It's 325, 4 times a day.
And that's helping to take the edge off? That helps take the edge off, Melody?
Yeah.
Good.
Yes, it does.
Good.
Yeah, it does. But what I don't understand is why does it?
Well, that's the opioids have their different effects on the body, whether they stimulate your endogenous endorphins or so forth. So they are helpful for all kinds of pain. I think our real issue is you develop tolerance to them. So for
Okay.
they are great for acute pain, but for long-standing chronic pain, they tend to lose their effect after a period of time as body gets used to it. And you need more of it. And this has been the fear of everyone. That may not be true in everybody, but that has been the concern, and that's why you have seen all this issue of opioid crisis that has gone around the country.
Right.
Losing about 60,000 people a year is not a simple proposition. And so,
No.
but there are then issues. How do you deal with certain conditions for which you don't have a good answer? And if that is what you can control it, you can rely on smaller doses and not necessarily having a goal that you are going to take as much as necessary to control the pain. So
is the doctor talking? Yeah. I think not.
Wouldn't you agree, Tim?
Who spoke up?
I said, wouldn't you agree with the concept?
I agree with that. I agree with that. But I wish there was another option besides, the gabapentin and opioid,
Have you tried Effexor or another type of antidepressant to help with the burning pain?
For me, Melody?
Yes.
Oddly, mine's not really burning. It's like you have a toothache, a bad toothache.
Have you tried Robaxin, like a muscle spasm med?
Mm-hmm.
My neurologist did prescribe me baclofen, but I never did try it. No.
You should try that. Pardon me?
I never did try it, and do you think I should ask for that again?
I would. A lot of people do take baclofen or Robaxin as an antispasmodic, because you can get that pulsating pain like a toothache, that throbbing, and that generates that whole trigeminal pain that starts like a migraine. It generates that type of loop, and that antispasmodic will stop that. It would definitely be worth a try.
I tried that. I ended up throwing it out. I will ask him again.
Yeah, I would try.
Before the availability of things like gabapentin and so forth, Alavil used to be one of the medications that helped that kind of pain. That's
which one, doctor?
Alavil.
Alavil?
Alavil, yeah. Elavil.
Oh, yeah. Okay, that's antidepressant.
That's a not so good antidepressant, but it actually is helpful for chronic pain.
They had me on a number of the TCAs, and that did not help.
I see. Okay.
Well, maybe give the baclofen another try, Melody.
Okay. All right, I will. Thank you. Thank you,
ladies. If the current's working, don't mess with it.
That's right.
I am hanging in there.
Yeah. That's all you can do.
Dr. Malik and I could go on for an hour about this issue.
Yeah.
I
that's true.
Too much
if it's working, it's good.
Right.
Yeah. If you're hanging in there and managing it, that's the main thing, right?
Yeah. Dr. Malik, I had a question about facial localization of rosacea with the innervation of the trigeminal nerve. It seems like all of a sudden, I've covered up with makeup, but I I got a swollen lymph node in my neck, and I'm just getting through breast cancer. Like if I brush up against it, it's still beet red. And I was reading about how the whole facial skin is innervated by the TN nerve, and you see a lot of people get the swelling and the redness. Is that a separate rosacea type inflammation from TN, or is that rosacea proper?
Yeah. That's a very interesting observation, because in doing the radiofrequency ablation, in some of the patients, particularly fair-skinned individuals, you can actually see the redness in the division that you are trying to treat. So as we heat up the nerve or the needle, it causes distinct redness in that particular division. Really, you can delineate it, whether it's the second division or the third division and so forth. So there is some sympathetic effect within that nerve, and you know, some of this pain that is constant pain and so forth might well be related to the autonomic nervous system, which is sympathetic and parasympathetic, rather than directly the nociceptors, the C fibers. We're going more into the technical side of it.
Yeah, it's just really interesting to me, because so many people post pictures of how swollen and red their faces are, and I'm just linking that with the burning that I experience, and it's
so that's true. I mean, that's my observation too.
So that's not really rosacea. That's just damaged nerves over 25
That's right.
years.
That's the nerve stimulation. Yeah.
Okay. Thank you. You got the wrong complexion for this.
Well, we're all in different phases and different exposures.
Yeah. Well, even with the sunlight, it's, you know, my skin I'm on tamoxifen, so that can kind of mess with your whole hot flashes and all that.
Right. Sure.
That probably adds to the joy. Thank you. Anybody else have questions?
Not this time.
Or Tom?
All right.
For Angie, Lynn, we were talking with her. I texted her at about 6 o'clock and said, you should have joined. You could ask Dr. Malik. And she just asked how. She must not have read my meeting notice. She's the one doctor that I asked you a month or two ago about the mental nerve, MENTAL.
Sure.
And I think it was Dr. Linsky that said cutting that or freezing it or whatever wouldn't help because the pain is in the brainstem. Am I remembering that correctly?
Well, so we used to cut those nerves.
Right.
Mostly
the mental nerve.
Mostly the infraorbital nerve or supraorbital nerve. So these are the end branches of these nerves. So in the first division, the end branch is supratrochlear or supraorbital nerve that comes on right over here, and it would cause pain in the forehead. The infraorbital nerve actually comes out below the eye, and it supplies this part of the face, the second division. The mental nerve comes out through the jaw and supplies this lower part of the face.
That's where her pain is, right?
Okay. So the problem with cutting those nerves is we did that actually quite a bit years ago, before we had radiofrequency procedures and all these other treatments that came through. So you will cut the nerve. Actually, in patients who are acutely sick and can't have much of a procedure done, I would actually in the office, I'll inject alcohol into the infraorbital foramen for this upper lip type of pain. And it works very well, but its effect lasts generally 3 to 6 months, and then the pain comes back. We used to cut that nerve, and that would give you relief on the every somewhere between 6 months and 18 months. And the pain then came back because the nerve regenerates. So same would be true with the mental nerve. Cutting the nerve is not necessarily giving a long-term relief. It would be a short-term benefit.
She's just trying to get out of it.
The 6 to 12 months it would last?
That has been with the infraorbital and supraorbital nerves. The mental nerve cutting generally would be the oral surgeons who would cut the nerve. The neurosurgeons, we don't do that.
Oh, you don't? Okay. Well, he's the one that tried to freeze it. What I'm looking down for is to pull up my invitation and send it.
I already sent it. I sent it to her.
Did you?
I texted it to her, yeah.
Maybe she'll hook up here. Thank you.
Yep.
She said the oral surgeon tried to, tell me if I'm wrong, Lynn, numb it, and he was having trouble numbing the mental nerve. I think he was thinking about cutting it, but he couldn't get the damn thing numbed. Is that what you recall, Lynn?
Yep, I do.
Yeah.
Yeah, well, you could actually, they are used to injecting that nerves. The dentists do it all the time.
Yeah.
She's got 2 pages of procedures. In fact, her and her mother saw you 10 to 20 years ago. I don't know. I won't get into that, but I'm trying to talk her into coming back and talking to you, but I haven't been successful. I was trying to get her into my pain specialist, and the last person I get in was Melody, and he's getting harassed by the state people because of opiates. So
yeah, that's true. So
he's in the top 10 in the state, but that's all he does is pain. He doesn't give antibiotics or anything else. So it's not surprising that he'd be in the top 10.
Correct. Yeah.
They're trying to get him to agree to a $20,000 fine, go on probation, and he's told them where to put it, so to speak. Anyway, separate issue. Hopefully Angie would get on. You don't handle that mental nerve, you're saying. Oral surgeons.
No, but I think stimulation-wise, we may be able to have Dr. Schwab look at it.
I know, and I tried to suggest that too, and I wasn't successful.
Yeah, but he didn't think it so too that would be helpful.
Oh, you asked him?
Didn't we ask him at that time?
I don't recall that. Your memory's better than mine. But maybe you talked to him and I didn't. No, but Schwab, I can email Schwab.
I think he was on the email.
Oh, was he? Okay.
He talked about, he was the head of the pain group for AANS.
You're not talking about your Dr. Schwab?
Sure, Dr. Schwab, yeah.
Yeah. I didn't recall. He said it wouldn't help?
That's right. He said that wasn't.
Okay.
Yeah, that's what I remember.
So the best bet is oral surgeon numbing it and cutting it for the last 6 to 12?
Or trying it to numb it first and see if that would help the pain.
She said he couldn't get it numbed. I don't know why. He's been helping her for 24 years. They came to us she's 38 now, when she was 14 or 16, to our support group. And she's had every procedure you can think of. There's probably so damn much scar tissue in there.
And she wants to be a dentist, of all things.
Yeah.
I'd love her.
Yeah. Anyway, so we lost track of her, and then Lynn picked her up on Facebook, coincidentally.
So
And
all the procedures have been in the jaw?
no. She said micro rhizotomies. I got 2 pages. I can fax to you. 2 pages, or I got them online. I'll send 2 pages of procedures she's had over the 24 years, and you just want to cry when you read them.
That's the trouble. We're so desperate for answers that we try anything, you know.
Yeah, like I say, Lynn and I lost track of her. And her I'm sorry, Marlene, go ahead.
Are you done? I'm sorry.
Yeah.
Yeah.
Go ahead.
I was just going to ask the doctor. He said he did 2 of these MVDs yesterday. How many of these does he perform a week? Do a week?
Well, it all depends. You know, there are certain seasons that you have more, and other times they have less. Generally, around this time, springtime and probably fall time, we probably do more, and the rest of the times a little less.
Okay. And why is that? I'm curious.
I think there is some seasonal effect on it if people become more symptomatic.
Oh, the seasons. Okay.
Yeah, the barometric pressure changes, and the swelling of the blood vessels putting pressure on the facial nerve and the trigeminal nerve.
And particularly those people who are on maximum amount of medication already, they just cannot take any more, so they tend to seek more surgical help.
Do you also do the balloon rhizotomy?
I don't use the balloon, I do the radio frequency.
Oh, okay.
You do the glycerol, Dr. Malik?
I don't do it, Dr. Schwab does it.
Okay, that's good to know.
Dr. Casey does the balloon, Marlene. I think I mentioned to you.
Right, okay, yep.
Lynn, did you text that or email it?
I texted it because I never know if she'll pick up the email, but she picks up the text always.
Yeah, she's not.
Yes.
They're delivered, so.
I got the email.
Yeah.
I didn't get the text, Lynn. I got the email. Thank you.
No, I'm talking about Angie, the one who's trying to get the frontal nerve cut. Thank you. Yeah.
Yeah. Well, we've got the info anyway.
Yep.
We can both talk to her, Lynn. Thanks.
Yep.
Anybody else? Melody?
Oh,
Linda?
I think that I asked what I was curious about. I appreciate the answers, Doctor.
Denise, you've been quiet. We haven't talked in years. I don't know if she knows.
Yes, thank you for the presentation. Thank you for the presentation tonight. I really appreciate it.
Yeah, Dr. Malik, you're wonderful as always. Thank you so
You're
much.
most welcome.
Yeah.
Thank you.
Yeah. This is
Tim and Lynn.
this is part of my family, so
You're the best. We love
this is
you.
a family affair. It's not
Dr. Malik.
doctors.
Dr.
Thank you very much.
Business.
Thank
That's
you,
a-
Pete.
Because
None of it
we-
would be
we-
possible without Peter Rupi.
No,
Junior.
Dr. Malik, I'm a mechanical engineer. You made this layman engineer understand. Thank you for the clear explanation.
Well, you know, the work that you folks do is so critical because this is a condition that has a lot of devastating effect on people's lives. And to have somebody away from the medical profession, helping the people, guide them, share their experiences with them is very, very helpful.
Thank you.
You know, anybody who comes to see me, I really advocate to them. I give them the information about Tim's number, and I encourage them to be part of the support group because we as physicians, you know, as the time is going by, we're getting less and less amount of time that you end up spending with the patients. And so you need all this extra support system for people to understand what the problem is. It's a little different than having, the belly ache and you got an appendix that is bad, and you go to the operating room, you get the appendix cut out, and you're healed and you're fine. Versus this condition that has so many different aspects that they are hard to understand. They are hard to understand by us who deal with it. But one of the problems that we face is that there is tremendous amount of information available these days on the social media and internet, and it's only portion of it that is valuable. Mm-hmm. So having the ability to talk to people who actually have suffered with it, okay, whether it was TN1 or TN2 or other variations of it, I think that's very helpful.
Thank you so much.
So I actually feel that the part that you play is, I think, very critical in the lives of the people who suffer.
Agree.
We haven't been getting referrals as much from the new neuros at Beaumont, excuse me, Melody, from the new neuro at Beaumont and the new one in Midland that we were getting from Dr. Piper and Dr. We lost 2 neurosurgeons over the last 5 to 10 years. So for whatever reason, we've had them speak, but we haven't been getting the referrals. One other question, Doctor. Have you done any pediatric MBDs?
No, for 2 reasons. One, it is so uncommon in the pediatric age group. And secondly, at Henry Ford, back in mid-90s, we actually closed the pediatric unit. So we have a lot of pediatricians in the community that are part of the Henry Ford medical group. Actually, we have more pediatricians than anybody else, but they end up admitting patients to either the Beaumont or more commonly to the Children's Hospital. So, and we don't generally operate. When I was here at Beaumont, I took care of a lot of pediatric patients, both trauma, newborns, others, almost about 50% of it.
No.
So we cannot, we don't have the ICU facility to admit children under the age of 14 or 15. Mm-hmm. So even some of my other work that with vascular malformations and so forth, we don't do that in that younger age group. But the youngest patient that we have had was our patient known to all of us in late teenage group that I operated on.
Yeah.
Okay, you know her very well. And the other patient was, I operated on the patient at age 25, but he has had the pain since the age 15. Mm-hmm. But I have not come across, I know the reports that are there that the young children have the pain, but it's so uncommon. So
I think it's wise.
I love to take care of children. That's not an issue.
Right.
But we just don't have the facility to take care of younger children.
No, it's wise that even the Facial Pain Association decided they're going to send them all to Dr. Mark Linsky in San Diego so that he has the numbers to make it, to learn from it.
I mean, it's no problem. Doing surgery is not the issue.
Yeah.
It's the rest of the support system
having
the thing. So, I've taken care of the children for all kinds of issues, tumors, blood vessel malformations, and so forth. So
Sure.
I think I copied you on the note. Dr. Linsky
Yeah,
has agreed to speak on November 11th with
yeah,
our
I
group.
saw that. That would be good.
And I
Okay.
don't think we've ever run into pediatric, have we, Lynn, below Angie? I
No.
don't know how you diagnose them in the first place.
Well, again, suspicion is the fact, but it is. If it were common, I would have seen it
Right.
in all these years, because even if we don't, let's say, in the last 25 years, we are not operating on young children at Henry Ford, but oftentimes they send them to me for consultation anyhow.
Sure.
Okay. So it's really rare.
As some of the new members wouldn't know, for approximately 5 years, Dr. Malik was head of neurosurgery at both Henry Ford, West Bloomfield, and Beaumont. I think it was about 5 years, Doc.
No, about 7, 8 years.
7 or 8, okay. Mohammed gave me the wrong number. So he was over neurosurgery at both hospitals. So that'll give you a little feel for his reputation.
And where's he at now?
That's amazing.
That's pretty good.
Where's he at now?
Henry
I'm with Henry Ford.
West Bloomfield.
Yeah.
Okay. Okay.
In the West Bloomfield Hospital of Henry
Okay.
Ford.
Okay.
15 Mile Maple are at what? What's the North-South Street?
Yeah, it's no, it's right off Maple.
Right, I know it's Maple.
The address
Maple
is,
and what?
I think 6777 West
Yeah,
Maple.
Maple and what is that
It's
North-South?
between. It's just west of Drake.
West
What?
of Drake?
West of Drake, yes.
Great, okay. I
And
forgot
Maple.
if I drive there enough. I should know by now.
Is that where his office is? Your office?
That's where the office is. That's where I practice. This is our new hospital, very fancy hospital. So
Okay. All right. Can I make my appointment now?
well, you can make the appointment. I can give you the number. You know, these days the computer people have to make the appointment.
I know. I was just kidding. I know.
No, but you can have the number. Tim has the
I
number.
think it's
Yeah.
6417, isn't it? 248? Yeah.
6616417.
6417, right.
Yeah, you can talk to Tony.
Yeah, Tony even came to our Christmas party last year. She was adorable.
Yeah.
She's
Tony Casey is his nurse.
Okay.
Nurse
Good.
and everything. Yeah. All righty. Thank you, doctor.
Thank
All
you.
right.
Thank you so
Most
much.
welcome. It's a
Thank you.
pleasure.
Have a
All
good
right.
Peter,
Nice
thank
to
Nice
you.
meet
to meet you, Lynn.
Yeah, nice to meet you too, Miranda.
Oh my gosh, Tim, I don't know what I'd do without you. You've been my saving grace.
Aw, nice.
Take care, honey.
Know that. Yeah.
Thank you.
Take care, guys. Thank you.
Good talking to you, Denise. Give me a call
Thank
sometime.
you. Okay. Talk to you later.
Take
Thanks.
care. Thank you.
Uh-huh.
Bye.
Bye.
Got to see how to get off, Pete.
Yeah, how do you get off of this thing?
My Peter's not here.
I can shut it all down if everybody's done.
I see something says leave. I'll hit leave, I think.
All
Thanks
right.
again, Pete.
Bye, Tim.
You
Bye,
look great,
Tim.
Bye, everybody.
Lynn, you
Bye.
look great.
Thank you.
Feel better, Linda.
I hope so. I'll let you know, and then I would like you to forward some contact for me.
Yeah, Linda, you really need to get in there and get something, as far as the electrical maybe.
I don't know. I need something. I'm just,
Yeah,
I feel like lately I'm hanging by a thread.
hang in there.
Yeah.
I'll say a prayer for you.
Thank you. And I also will mention to you that when I go to the dentist, I have them give high dose nitrous, and that helps.
Oh, that's
Yeah.
interesting.
Yeah, my dentist is very good. with me, and when he has to work on the left side, which is my affected side, he ups the dosage to maximum.
Good. Thank
Yeah.
God. Yeah.
So I have found that helpful, so you could try that with your dentist, have a discussion, and it might be a much more tolerable procedure for you.
Yeah. What did you say it was called?
Nitrous oxide.
Oh, yeah, like for laughing gas?
Yes, absolutely. It makes one happy and tolerable, Mm-hmm. Mm-hmm.
Okay. Sounds
Yeah.
good. Okay.
Very
Thanks.
nice to have met you.
Nice to meet you too. Hang in there, please.
Thank you.
Bye.
Good night,
Oh.
lady.
Goodbye.
See you later.
Bye.
Hang in there. Bye-bye.
Thank you. Bye-bye.